If they are in the hall, please, if they can come and take the chair. We've got very interesting presentations. The first presentation is from a guest speaker, Sami Al-Rabai. He's going to talk about post-LASIK IOL calculations. This is one of the topics that all of us are like really confused about because there are different ways of calculating about it. And I would request Dr. Sami to please give a talk. Thank you so much.
Assalamu alaikum wa rahmatullah. Okay. Bismillah ar-Rahman ar-Rahim. IOL calculation post-laser vision correction. It is really a challenge. It's a major challenge. Most of formulae we use end up with surprises. And why is that surprise? Let us just go simply. If you want to do a cataract for a simple patient, you ask your resident, please do biometry. And to do biometry, he does two things: axial length measurement as well as the K-value measurement. And then he put this, and simply he gets the formula, right? Now, axial length has not been too much changed after refractive surgery. It's only few microns, 40 microns, 30 microns. It does not really make change. It is in the K-value. I call it the magic or the amazing K-value. Why it is amazing? Now, the K-value taken by any of our machines is not on the center of the cornea. Yet, by the K-value, we know the power of the center of the cornea. How is that? Because we all know that the cornea goes flatter, the way it goes from top. If you are going to the mountain, a few days ago I was with Professor Hussein, and he was saying that this is the highest and that the high is so and so and so. How do you measure the height from an area that you are not there? If you around this mountain by few points, and you know that this mountain is going this way, and you know your distance from the tip of the mountain, and you know your height now, so you can know your height at the tip of the mountain. Exactly, this is what's happening with K readings. You take the K readings either in 4 points or 6 points or 8 points or 2 circle, whatever. It is always in circle. It is never on the center. But these circles has diameter, and once you know the power of all this circle and this diameter, you can judge the K readings up. This is one point. The other point, you have the K readings. And the K readings only the anterior surface of the cornea. Yet, you have to pass the light through the anterior as well as the posterior surfaces of the cornea. So how come by the K readings you know the total corneal power? This is because there is relationship between the anterior and posterior. We all know that the posterior surface of the cornea is not exactly the same curvature as the anterior. It is slightly more convex. But there is a relationship between them. It's about 82%. So if you know one, and you know the 82%, you can know the other. And if you know the other, so you know the both, and you know the total corneal power. See how amazing this K reading. And then, the K reading can tell you, if you go to a small room that has only 20 chairs, you know that only few doctors will come. But if you lecture in a big hall with 2,000 chairs, you know it's a major lecture. It's exactly the same idea. How come? If you take the K readings and it is 46. 46 usually belongs to high myopic eye. And high myopic eye means large AC depth, which means the effective lens position is deep. On the contrary, if the K readings is 41 or 39 or 40, so most probably it belongs to hyperopic eye, small K readings with shallow anterior chamber. And the effective lens position is not that deep. It is forward. So this K readings give you 3 data. You never thought that this will give it to you. Okay? Now, what happens after refractive surgery? First of all, you change the anterior surface of the cornea. So you are here, you cannot measure the tip because this, what you usually calculate, is changing. It is getting flatter if you are trying to do myopic correction, or if you did myopic correction, and it gets steeper if you have hyperopic correction. So the K readings is not happy about that. And then if the patient's supposed to be 42 in the beginning, he's a normal person, but he was hyperop, and you corrected him and he became 47. Now when you send him for biometry, the machine takes 47. This is myope. So it's a big effective lens position. And he was not so myope. He was even hyperop. On the contrary, if somebody who's 42 and he was myope by 4 degrees and you corrected him and he became 38, and then you send him for biometry, the machine says 38, shallow. So it's a small eye. So he was hyperop. And this is again, he was not hyperop. So the machine suggests now something different from what's the beginning by the curvature of the cornea. And then reading our measurement. What's this? This is about the corneal shape. It changes. It seems to be either deep or shallow by changing. And then this is the radius, corneal surface anterior to posterior, which is 81. And this is the measurement. As we said, it is not in the center. It is around the center. I'm sorry, I thought it was working. Now, and this is here the power of the cornea. So if it gets flatter, the machine thinks it is shallow AC, and this is what? Now this is the machines we are using. These are drops, by the way. Not. Look at these drops there. Here, there is something wrong with the projector. So the machine, all our machine, they don't take in the center. They talk all around. Whether you have the keratometry or the IOL master has 6 points, the keratometry 4 points, A-scan 360 points, but still 1 or 2 rings all around. The only one that goes to the inside is the APP. It is the average pupil power. It makes 8 rings. It goes to the inside. It is called the APP. And the APP, which is the average power of the pupil, from which we can take the ECCP, which is the effective central corneal power. Okay, we will talk about that. We said that we change only the anterior surface. We don't change the posterior surface, and we have to calculate both. So the formula of 82, which we just mentioned, is wrong. We have to know both. We have to calculate both anterior and posterior, and we said here that it is changeable from 82. It's not more 82, and we have to think of something else. Many formulae had been described. The clinical history method, you calculate how many. Suppose he was -4 and he's now 44, so most probably he was 45, and then you calculate. So history. Or contact lens, you put in contact lens, you do a hard contact lens, and you do over refraction, you can suggest how many remaining. Or topography based, post LASIK, which is Koch, Wang, and Shammas. Or you can, as Awad, central ring topography method. But and then Muscat. But I'm talking about the ECCP and the net corneal power, because these are the things available at every one of us office. ECCP, effective central corneal power. And this is taken by OBD 3 NIDIC, OBD scan. And the net corneal power taken from any Schimflong, Pentacam, Galilei, and so on. We will discuss that one by one. We said the average power of the cornea, this is taking as picture of the whole cornea. So it is measuring the power of the cornea inside. This is the only machine that goes to the inside. So it represents the keratometric value inside here. Yet this is not enough. What is the effective central corneal power? This goes to, look at me carefully. It reads the average power. This is the first of all, at 3 or 4 millimeters. And then it goes to the 9 millimeters away. It goes to the 9 millimeters, and then it looks to the knee. What is the knee? If you do refractive surgery, if you do myopic correction, it is flatter here, and there is a knee. There is increased convexity of the periphery, which is Q value and so on, many other names you have. We call it the knee. So it looks to the knee, how much this knee is being bent This means how much this flat has been gone down. So it measures now here, and then measures the knee, and then it suspects how much we can go if this knee is 0, so this one is corrected. And this is, so it builds up the anterior, the expected anterior surface. And then it looks to the, again, to the 9 millimeters, to the posterior corneal surface, and has the corneal surface. So it goes back, now it has the known the corneal surface, posterior, as well as the anterior, the new one, and has the formula, they added together and divided by 2. This ECCB, this very genius idea by Jack Holliday, done a few years ago. Okay, finishing. So this is the ECCB, and if you look carefully, because the time is gone, ECCB is better. In normal case, there is no difference. But once you do myopia, there is differences about 0.66 difference. And this is in myopia, it is 0.9, in hyperopia, almost 0.4. And then the Schimflung is an excellent data, and this is the most important, because Schimflung calculates the anterior and posterior. Okay? So it calculates both. Look at this. This is the anterior, and this is the total, because it calculates anterior, posterior, and then get the total. Now we look here. This is the manual ordinary one. The number is something around 17. This is the people by manual, and if you do by hatch time, slightly high, 17.5. If you do it by SCB, it's 18. If you do by Galilei, it's 19. So if you want to calculate on this, it will be 17, here 19, and 2, there's a difference, and this is that, that's right. So that's why I advise you to go for the zone anticipation 24 is your average. Normal, if you ask your doctor, and this you sort of the problem, about 3 days and the same here. And we have communication, I'm not going to go, but this is the Galilei gives us better results in the myopic, post-myopic, than the other. This is the regular, how far is it, big surprises, and the ECCB gives us better results in minus than the Galilei, and this is the 0, this is the ECCB, and this is the regular one. So far, so the ECCB is more to the minus than the Galilei. So I advise you, if it's both myopic, to go for Galilei, or particularly the Schimflung, if it is hyperopia, to go for the ECCB. Thank you.
Thank you so much, Dr. Sami. It was a wonderful presentation. I would request if you could stick around, because we are going to have question and answer sessions at the end of the talk. Now I would like to request Dr. Miguel Richichi to come and please talk about flax still a novelty. Is Dr. Miguel in the audience, please? No. Our next speaker is Dr. Yahya Salahuddin. If you can please talk about the flax for challenging cases. I'll just like to remind that the talk time allocated to us is around 11 minutes. So I'll be giving the bell at 11th minute, please.
Perfect. Thank you. This is my last talk in this wonderful meeting. So flex or femtolaser assisted cataract surgery, I didn't used to be a great fan of. It's a lot of pressure from everybody to talk about flex, but I think for me, I found some indications that one of the main indications for me is using it in treating astigmatism associated with cataract, doing intrastromal astigmatic keratotomy, 1 to 3 diopters, and this is for me, it's a justifiable indication. And second, which is my talk about challenging cases, and two of these conditions are shallow anterior chamber and subluxated lenses. It could be a fuse. and of course, as I said, astigmatic keratotomy. So the machine, or the beginning of I use the Zimmer, which is a very mobile, easy to use system, and it uses this way of docking, and it's water interface. So the water interface is very useful because there is no high increase in the intraocular pressure, and you can, in a shallow chamber, it's very easy to make your plan your incisions, and do the capsular access. Maybe in a shallow anterior chamber, one of the most important things are the capsular access, ease of capsular access, and the second is placing the incision and making them properly watertight. So it's very simple to do, and you check everything on the doing intraoperative OCT. So one of the challenges is the shallow anterior chamber. A shallow anterior chamber, if you do regular phacoemulsification, you can do it. You can have different ways to go around it, but still it carries a challenge. One of these challenges is the capsular access. And this is like a regular phaco in a very shallow anterior chamber, previous glaucoma surgery. Although I don't use much of ring iris hooks, but you can see the small pupil and the positive pressure that is present, particularly with the shallow anterior chamber. So all the time you will have difficulty doing the rhexis. You have to stop many times. You don't want to have an extended rhexis, and the positive pressure will let the iris prolapse all the time. So it's an important step, but it can be risky and challenging if you're doing manual phacoemulsification. So this was the first eye of the same patient. The second eye decided, why not? I have the machine, why not to try to use it? And this patient had a chronic angle closure glaucoma. And that eye, he did previous peripheral iridotomies, and you can see peripheral anterior synechia. And here I have skipped the challenge that I had in the other eye, and I have a perfectly made center capsular access. Now I can go from the paracentesis to do viscodissection and viscosyneculysis of the synechia present at the angle. You can see the areas where the iridotomies were done previously. Under viscoelastic, I'm doing this viscodissection. Actually, in chronic angle closure glaucoma nowadays, the use of phacoemulsification together with goniosyneculysis is a very efficient way to control the intraocular pressure post-operative as well. So you see the rhexis was no problem, and the incision was better constructed, so there is no iris prolapse. It's the same patient, but the other eye. And I do usually 6 segments, but it's not the main problem for me in that patient. The segmentation is already done, and again doing viscodissection. And in any glaucoma patient, you really need to protect the corneal endothelium. You protect it by viscoelastic, you protect it by the proper technique working essentially in the capsular bag, as well as using the least power that is needed to remove the cataract. You see it's already pre-sliced. It's not a hard cataract. And if you can use the phacoaspirate, only vacuum, and the ultrasound, you will use it only just to help you aspirate the nucleus. So working in the posterior chamber, protecting the corneal endothelium. And the capsular X is now done with this LDV. It's a very low energy machine. So the Rexis is really as well as strong as a manual Rexis, not like other machines or earlier models. And the irrigation aspiration is done as normal. And here you can see there is like a sort of plaque over the posterior capsule. I will try to peel it, and it doesn't peel. Then I will do a posterior capsular access. The same way, if you attended my lecture yesterday, you inject viscoelastic to push away the anterior vitreous face, and then you do the rhexis. You inject a bolus behind the posterior capsule, then a bolus in front of the anterior capsule, then you do a posterior capsular rhexis, so this patient will not need yak capsulotomy post-operative. And after doing the posterior capsular rhexis, you inflate the bag in different points, because this is not a continuous bag. You inflate the bag, and then you implant the lens of your desire in the capsular bag in front of the posterior capsule, the capsular axis, and behind the anterior capsular axis. Then once the lens is inside, I will try to stretch and open again the angle, because this is very important for the post-operative control of the intraocular pressure. This stretching, sometimes you can induce some bleeding from the angle, the root of the iris. Then if this happens, just stop, increase the pressure inside the eye. And this is vesicosyncytial again, now with less volume because of the removal of the lens. And of course, if you have a direct gonio lens, you can do it under vision. Okay, in mature cataract, this is just to show that in some people who has difficulty in intumescent cataract doing the capsular axis, the femto cataract, the flex or the femto laser can be of help to help you to do a regular and continuous capsular axis. There is one missing movie. There is one missing movie called Subluxation. Not this one. Not this one. So if he doesn't, no, not this one. Not this one also. There is one called Subluxation. Okay, anyway, I hope that I could show you that movie, but I don't know how it is lost. I uploaded it. Oh no. So I'll check if I find it, maybe later if we have time to show it. But in subluxation as well, it is useful because as I have seen in the session of subluxation, sometimes it is difficult to do a capsular axis, and sometimes you will induce more stress on the zonules in such cases. So femtolaser is not the only way to do surgery, cataract surgery. It's not the way to go now, but still it has its advantages in some challenging cases. Thank you for your attention.
Thank you so much, Dr. Yahya Salahuddin. It was a very interesting presentation about femtocataracts and very, very interesting cases of glaucoma. Our next speaker is Dr. Muhammad Amjad, if he is in the hall, please. Our next talk is again by Dr. Sami Al-Rabai, if you can please come and deliver the talk.
Bismillah ar-Rahman ar-Rahim, talking about the unhappy post-refractive cataract surgery patient. Now, we discussed that before, which is biometry and the surprises of biometry because of the K readings. My amazing K readings is forgotten. But also here we have to discuss the Q value that is not measured in normal healthy eyes. And we said the amazing K value, the importance of it, that that after hyperopic correction, you have steepening at the periphery. After myopic correction, you have steepening at the periphery and flattening in the center, while after hyperopic correction, you have flattening in the center and steepening in the periphery. And this, we discussed that just earlier about the effective lens position by changing the K readings, and the machine is misleaded as it is myopia or hyperopia, while it is not in both cases. And we talked about the measurement, that the measurement are not at the center at many points, but it is in a ring. And once you know the ring and you know the diameter, you can know the power. And we said the anterior and posterior relationship. And the many formulae, we discussed that. Now, what about the periphery? This is the second step or second thing of failure of your surgery. The Q value, the asphericity. What's the Q value? This is the normal, this is a normal sphere, rounded. And if our cornea is like that, the light at periphery will be reflected here, not at the retina. So all the light, once you go from outside from the center, the light comes higher and higher and higher. And this is what we call positive spherical aberration. But God did not make it like that. Alhamdulillah, we are getting flatter cornea, which is prolate shape. And this flatter cornea more and more, so it pushes the light at the periphery to go down to be centered at one point. So this is aspherical surface, and this is spherical surface. And now what is happening? This is pre-LASIK normal. Now after, if you look here, after hyperopic LASIK, there is flattening here. So the peripheral cornea is flatter. After myopic laser, the peripheral cornea is steeper. What does that mean? Again, we go back. We said if this is normal cornea and if this is a normal sphere, the reflected light at the periphery will not be here, will be here. But our cornea is flatter, so it's instead of being here, it is down. So it is pushed down. Okay, this is normal prolate. You may ask me why it is not at the zero, because there is still lens here coming, and the lens will add to the peripheral cornea to make it at zero. So this normal phakic. Now, if you do myopic correction, we said myopia is increasing sphericity. So the light, instead of being here, it is going higher. So it is more hyperopic and more positive spherical aberration. And if you do hyperopic correction, it is flatter, so it is less hyperopic spherical aberration. So in all cases, this is positive spherical aberration. This is the zero, this is the normal, and this is the over, and this is the less by myopic and hyperopic correction. And we said as before, the normal cornea is about minus 0.26, added to it minus 0.25 of the lens, and this gives 0.52 the total, and it comes to the retina. As a matter of fact, it is not on the retina; it is about 10 micrometers from the retina, which is give us something about the depth of vision. So negative asphericity, prolate of the cornea. So we have to understand. Now, this is all inside. This is very good spherical. Look at it. And this is if they are not inside. And this is what we call spherical aberration. And this is the normal cornea. This is after myopic correction. It is steeper here. After hyperopic correction, it's flatter here. And if you look at the changes here, this is after myopic. This is after hyperopic. Look at the spherical aberration. Spherical aberration here and spherical aberration here. As we said, myopia increases positive spherical aberration. Hyperopia decreases positive spherical aberration. And again here, this is the same thing. I'm afraid of time. Now, we said theoretically the average corneal asphericity is about minus 0.25, but yet the mean is plus what? Plus 1. You said how minus and plus? This is spherical aberration. This is asphericity. Asphericity is related to the cornea. Spherical aberration is related to the point of fixation to the retina. So don't mix this together. Measuring the spherical aberration of the cornea allows us to predict. Now, there are lenses with minus spherical aberration, and there are lenses with plus. So you have to look at your patient. If your patient has, if your patient needs more positive aberration correction, you go to the plus ones. But if you're to the plus one, if your patient has myopic correction and you have to give him less, you have to go to the minus one. And here we are. Look at. I'm sorry, I can see. To have a happy patient. Thank you very much.
Please, we had a very interesting video. Dr. Yahya is going to display the video and talk about it, please.
Found the video and he will play. This is just to show you in subluxation how we can use the femto laser and how possible. This is an old hypermetrope. He received trauma. This was traumatic subluxation. There is vitreous prolapse, subluxation, and the pupil is atonic. So you have to address each problem alone. First, you have to tackle the vitreous that is prolapsing, then the cataract. And what made things easy here that already I've done the incisions and the capsulorhexis before I start, then removing the vitreous that is prolapsing from the area of subluxation. And as you know, this is traumatic subluxation, so there is injury in the zonules in one area, but this is not a progressive disease. And then you try to use all the tricks you have. I want to stabilize after I remove the vitreous, stabilize the lens to be able to do a proper phacoemulsification and safe phacoemulsification. So I used 3 capsular hooks, and I prefer capsular hooks over iris hooks because they are longer and blunter, so it's safer to have them. The iris hooks can tear the anterior capsule. So with this, and you can add the number of hooks you need according to the case, but here I needed only 3. So I'm doing my regular phacoemulsification. The only difference is the infusion is lower than usual, so maybe like 50 centimeters height, and everything goes a little bit slower. I always use vertical chopping with the Neumann splitter. And as you can see, the main player is vacuum, and ultrasound just helps to aspirate, helps you to aspirate. It is not ultrasound. If you have a prolapse of the iris like I'm having here, just don't reposit the iris. Continue. I'm continuing the irrigation aspiration and splashing the posterior capsule just to loosen the cortex. I don't want to manipulate more because I don't want to insult the area of zonulisis. And then I put a capsule tension ring. This was a Sayoni ring, which the only ring I had, I didn't need to suture it, so I could have used a normal capsule tension ring. Now I'm releasing the capsular hooks, then implanting the lens. And I chose to use a 3-piece lens, and here the advantage of a 3-piece lens, it adds for the stability and the better centration of the capsular bag, even with the use of a capsule tension ring. The iris was flail, so a lot of challenges was flail, and the pupil, remember, was atonic, so I started to stretch the iris and see what can I do to correct this atonic pupil. So I decided to do an iridoplasty just to keep the iris from the angle of the anterior chamber and to prevent it from floating all the time and to solve the problem of the patient having halos or glare in the morning or with the strong lights. And this is how the post-operative 2 days. Thank you for your attention.
Thank you so much for a very interesting video. Next speaker is going to talk about cataract and refractive surgery, how the cataract surgery has become a refractive surgery. I would request Dr. Monia Kior to please come and deliver the talk, please.
Thank you. I'm going to talk about the correction of presbyopia after cataract surgery. I have no interest. So, as you know, loss of accommodation after cataract surgery is a common problem. It's not restored by monofocal IOL, which is the most widely implanted wide world. Also, loss of accommodation leads to spectacle dependence. So, how to compensate the loss of accommodation after cataract surgery? We have accommodative IOLs, but these IOLs are still controversial and there is no approval implant. And we have the pseudo-accommodative IOLs like multifocals IOLs and extended depth of focus IOLs that provide patient distance, near and intermediate vision, and therefore glasses independence. Nowadays, as you know, there is a large panel of IOL available, and the patient undergoing cataract surgery have the flexibility to choose one of the different IOLs depending on their ocular structure and personal preference. So, with the surgical techniques, the precision of biometric devices, the evolution of the IOL calculation formula, coupled with premium IOLs, we see the cataract surgery has become a real refractive surgery. So the question is, which implant for which patient? So we have a lot of success keys of presbyopia correcting IOLs. First of all is the patient selection. So we have to exclude night driver, aircraft driver, patient with hyper-demanding patient or anxious patient, and patient who have a history of ocular of general pathologies. The second key is patient information. We have to ask about the patient's requirement, spectacle dependence, type of vision, lifestyle, expectation, and especially explain to the patient the advantages and disadvantages of presbyopia correcting IOLs, notamment, especially photic phenomena, and inform the patient of a possible change of decision in case of intraoperative incidents. And finally, informed consent must be signed by the patient. Sans oui, c'est un non. Without yes, it's no. We refuse the intervention, the surgery. The third case is pre-operative ophthalmologic assessment. So we have to know perfectly the patient previous vision status, and especially the history of refractive surgery. As Dr. Semi said, it is challenging to calculate the IOL after refractive surgery. And do not hesitate to use cycloplegic at any age to have an accurate refraction. Second assessment is a dry eye. As you know, dry eye is the main cause of dissatisfaction of the patient. So we have to assess it and, of course, to treat it before surgery. Also, corneal abnormalities must be screened with the corneal topography, aberrometry, ISOCT, because this corneal aberration can lead to inaccurate biometric measurements, incorrect IOL selection, and reduced visual performance and patient dissatisfaction. The pupil diameter must be measured, and we have to exclude extreme pupil size. Also, for patients that they had large angle kappa, we have to exclude them because of the risk of increased photic phenomena. In case of focal zonular wicks, we can put a capsular tension ring, but if we have large zonular wick, please avoid putting this type of implant because there is a risk of decentration, tilt, and IOL dislocation. For IOL calculation, target refraction is, of course, emetropia. This has been possible by optical biometric devices and new generation formula that can allow us an accurate IOL calculation. Surgical technique must be perfectly perfect. So we must do an incision that didn't induce surgically induced astigmatism. Please, video, please. And the rhexis must be perfect, round, and well-centered, and the size must be about 5 or 5.5 millimeter. And after phacoemulsification of the nucleus and removal of the cataract of the cortex, the implant must be implanted in the capsular bag and well centered. And be careful, we have to remove all the viscoelastic even behind the ICL. Per-operative exclusion criteria are posterior capsular tears, vitreous loss, etc. And here we have to avoid primer IOL, and we have to implant monofocal IOL. Of course, patient was informed. Finally, post-operative assessment and patient satisfaction. We have to assess visual outcome, spectacle independence, quality of vision, contrast sensitivity, and this may be done after binocular implantation. But sometimes we can be faced with unhappy patient for different reasons, poor vision, spectacle dependence, but the main reason is photic phenomena. So then in this case, we have to explant the IOL. So in conclusion, presbyopia correcting IOLs are safe and effective for the treatment of presbyopia after cataract surgery. But we have to understand the patient lifestyle needs and visual expectation, and we have to select the right IOL for the right patient. Above all, remember that one size does not fit all. Thank you for your attention.
Thank you so much for a lovely presentation. I would request Dr. Saeed Iqbal, if he's in the hall, to please come and make his presentation, please. Dr. Saeed Iqbal. If our We'll wait for Dr. Saeed Iqbal. If Dr. Mariam Harouche is in the hall, please. So I'll just repeat a few of the speakers who are missing if they've come up late. Dr. Miguel Richichi, Dr. Muhammad Amjad, Dr. Saeed Iqbal, and Dr. Mariam Harouche. So I've got a last presentation to make, so we'll carry on with that. So I've got two presentations on femtocataracts, so I'll just go back to back. By the time I think Dr. Mariam is going to be here. Actually, it's femtocataract from start to finish. Dr. Saleh has already talked quite interesting, given an interesting talk about it. Femtocataracts becoming popular, and most of the people keep on asking whether they should have a femtocataract and they should replace it 100% with a phaco and go on to femtocataracts. Well, what I think is not the case, because most of the time when we are dealing with cataracts, we have to make a choice whether we want to go in for a femtocataract or we have to go in for a simple phaco. Because it is not like which procedure is better than the other one. It is not the fight of technologies, but it is more like we cannot compare the two, but these are the two procedures which complement each other. It's more like there are few patients who would be more suitable or they'll be demanding for a laser cataract surgery as compared to the one who would rather go in for ultrasound. So it is more of a surgeon's choice, but patients do have a choice in making, like whether they really want to be going on with a standard phacoemulsification or a femtocataract. But there are like certain indications which do have like, which do favor it for going in for a femtocataract, as if there is astigmatism, so that we can do arcuate relaxing incisions. That would make life certainly more easy. This is what I've found. Certain types where our zonules are weaker, I prefer going in for a femtocataract, and there are, one thing that I've noticed with a femtocataract is more time consuming as compared to a normal phaco. When we are planning for a femtocataract, initially it is important to have good selection of patient. As the confidence grows on, we can carry on with general normal cases or difficult cases as well. So initially what I thought was like in a shallow anterior chamber, as Dr. Yahya has already mentioned about it, I found femtocataract to be a blessing because we do not need to do a lot of manipulation, and we get a full capsulotomy with segmented lens inside the eye. Similarly, I found it when the orbital margins are way too prominent, and these things can be really easy because we can simply set the things in very easily. Now this is like, we've already seen this videos in a previous presentation in which we see the docking of an interface, then filling it up with the fluid and attaching it, attaching the laser head with the help of the laser head to the interface. There are different ways of holding the interface, but initially for people who are starting femtocataracts with Z8, this is like the recommended way of holding it once we are doing femtoLASIK. But if we are going to attach it on a femtocataract, it is preferable to have two fingers in the front, because otherwise this thing is going to interfere if we are going to clip it on to the interface. But as the experience grows on, it doesn't matter which way we are holding. Once we've got where we all set, it is very important to position the eye in a way that it is all flat, so that, or we can tilt it if in case of deeper eye set. Normally, when we are doing stigmatic keratotomy incisions along with femtocataracts, we mark the cornea, or we can use reference blood vessels, and there are 2 pointers on the cartridge which has to be aligned as with the system, so that we can get exactly the markings right. There are like this is like the vacuum set, and the post laser we get a main incision, and then we get the arcuate incisions along with it. In this case, we can see the main incision, the arcuate incisions, and the side port incision with a capsulotomy in the middle. Filling it up with viscoelastic. Can you put it on again, please? Filling it up with viscoelastic, and usually we end up with a free-floating capsulorhexis. But one has to be sure, because there are times when there are adhesions and the capsulotomy is not complete. And if that is the case, excuse me, no. इसी को pull out कर दें. When dealing with stigmatism, we should be aware about like a higher degree of stigmatism is less common as compared to low degree of stigmatism, and we need to be sure like what type of stigmatism are we treating, whether it is with the rule or against the rule. There are different reasons that we can find like for why people are not using femtocataracts, and the study that we did was to plan the treatments, whether it is safe or not, and the planning was whether to treat the stigmatism with toric IOLs or with keratoid refractive surgery with femtocataract, and not to treat them. We looked into the location of the stigmatism, age, power, status of the fellow eye with the rule or against the rule. We calculated with refraction keratometry and tomography. Used the Nichiman femtocataract formulas to treat the stigmatism. Initially, we had the measurements was like around 2 to 2.25, and the results we got was like gradually stabilizing of the cornea. Initially, we were not titrating our stigmatic incisions. Now, what we have started doing is to titrate our stigmatic incisions. What I mean is, initially what I used to do was to open up the stigmatic keratotomy at the time of on the table. Now I'm not opening them up on the table. What I do is like I titrate it, like once I open one side of the incision on my first week post-visit, then I monitor it, and if required, I open the other side of the stigmatic keratotomy incision as well. The thing that we found was that these stigmatic keratotomy or the arcuate incisions with laser are not only very effective, but they are very safe as well, because in the whole study we did not find any complications like perforations or irregular stigmatic cut. So I'm still in time, so I'll carry on with my second presentation, please. So what were the differences that I found between the incision, that is the limbar relaxing incisions with knife, and the arcuate incisions, is that it is absolutely more precise as compared to the one that we give with the knife, because it is not only in length but in depth and arcuate size or the degrees. It's more perfect and it's more calculated. The location is more exact. It is like absolutely onto the location where we want, and especially when it is required to be arcuate at odd angles, we can be very, very much accurate, because we may be very good giving arcuate incisions with knife, but they can never be with as much ease as with a femtocataract. The other thing that we found out was the economics, because if we are trying to deal with the lens and a toric lens, it becomes a little more expensive, and if we are going in with the femtocataracts, it is a built-in solution, so that although femtocataracts are not very economically feasible, but still we do not get an extra cost of putting in a toric IOL. As far as the complication, I've already talked about that the perforation is a absolutely rare thing, because we have got a live OCT that can check whether we are going through the cornea or not, and we do not go in extra bit because it's a very calculated incision. The other thing I really found interesting was that we can change or move the degree of the stigmatism as even we get on the final stages before going on to the executing phase. Now, the important thing, the last point is that if I have got a choice whether to go have a knife onto the cornea or onto the laser, it said like that the picture is 1,000 words, so we can see which one is going to be, sorry, it's up here, not here. So, these are like comparison between the stigmatic keratotomy done with knife and with laser. So one can imagine which type of stigmatic keratotomy would we like to have it done on our eye. And this brings me to the end of my talk. Dr. Mariam was here a moment back. So, thank you. Right. Sure. Yeah, we have started doing it now. After the study, we've started doing the intrastromal as well, and we use at the 8 millimeters, and I'm using the Nichiman. Nichimans. Yeah. Initially, we were opening up the stigmatism. Yeah. Yeah. Initially, for stigmatic keratotomy incisions or the arcuate incisions, it is important to split the incisional area with the help of a spatula.
Repeat, I was handing this.
Yeah. With the arcuate incisions to be more effective, it is important to open up the incisional area with a spatula. Initially, we were doing that, but now we are not doing it because we can titrate if we do it in the clinic. This is what I found more interesting.
And you're doing it in your office or in the OT?
Yeah, on the slit lamp.
Okay.
Yeah.
Some video would be nice next time if you can make.
Sorry?
A video of that.
Oh
would be
yes, of
nice
course.
next
For the next presentation, we'll definitely do that. Yeah. It's quite a simple thing, but the instruments need to be sterilized for going into the wound. I only do. Sorry. Absolutely. The incisions are given on the theater table with the laser, but we open it up 1 week following surgery. So our next speaker is Dr. Mariam. She's going to talk about ASOCT in refractive surgery, please.
Dear colleagues and friends, I shall do my presentation in anterior segment OCT, CASIA 2, in refractive surgery. So the first indication is for laser vision correction. The anterior segment OCT give us the 4 maps, refractive maps, with axial maps, elevation, anterior elevation, posterior elevation, and a map of pachymetry. After we have the topography, we have the analysis of Fourier analysis that give us. Oops, sorry. So we have in the Fourier analysis, we have the spherical maps, we have the regular astigmatism, and we have the asymmetry in the axial map. So it's extended the regular astigmatism by the asymmetry. And after we have ectasia screening, the ectasia screening to have element for keratoconus or not. After we have the epithelium map in 10 millimeter diameter of 10 millimeter. So with this we can, the patient is eligible or not for laser vision correction. The OCT also give us the follow-up after corneal laser. Here we have the saturation of the treatment, the axial power, and we have also anterior elevation, posterior elevation, and the map, pachymetry map. This is the Fourier analysis post LASIK, and we show that we haven't any asymmetry in the axial map. After we have the screening of ectasia and no ectasia for this patient after LASIK. And we have the differential map before and after and the treatment. And here we have the summary with the delta average keratometry, the cylinder, and the mean difference between before and after. This is a patient who received SMILE treated by SMILE. This is before. It's the study of his anterior segment, and it's post-SMILE 6 months. This patient developed a regression of her myopia, and in 6 months she has minus 0.5 myopia. And corrected visual acuity decreased to 810. So why? We check the epithelial map. This is before. This it's at 1 month, and this is at 6 months. And here we have a very thickness of the epithelium. So it's why we have this regression. So it's very interesting to do the epithelial map by the OCT. This is a patient who wants to correct his vision by LASIK. So we have the diagnosis that we have first stage of keratoconus. We have E minus S1.3. His pachymetry is 480/10, and when we do the analysis of Fourier, we have asymmetry in axial map, so it's suspect keratoconus. So it's not eligible for vision laser correction. We can use also the OCT after LASIK, and we have the flap. We can measure the thickness of the flap. So it's very regular. It's about 100 micron, and we have no problem in the slide of the OCT. Now we can OCT also for keratoconus. So it to the diagnosis. The diagnosis we have E1S for dioptry, and the cornea is thin. And when we do we have in screen, we have the keratoconus in ectasia screen, and with the analysis of Fourier, we have the asymmetry, the axial asymmetry, very with the coma. In keratoconus, it's the analysis of Fourier. I talk about this many times. We have the axial of the asymmetry, and when we adjust the axis of the astigmatism by the axis of the asymmetry, axial asymmetry, the visual acuity is better. When we use 135, it's the axis of astigmatism in topography. The best visual acuity is 410, but it rises to 810 when we use the axis of the asymmetry, axial asymmetry. Casia 2 of keratoconus also to do intracorneal rings. So we have post-operatively the rings, their orientation. And this is a patient who is received intracorneal rings and ICL phakic IOL. For phakic IOL, it's very important to do the anterior OCT. Casia 2, he gives us the anatomical security by the crystalline lens rise and by the anterior chamber depth. It was 3.2, so it is eligible to do this implant ICL. After we give us the ICL sizing by the informer Nakamura, with the diameter of the implant ICL and the expected vaulting and the anterior shaft, anterior depth of the anterior chamber. So Casia 2 also we can use it to planify for IOL, multifocal IOL. And we have, if we have the astigmatism, if we have the regularity of the cornea, and they give us if the patient is eligible for multifocal IOLs, like this patient. So we see the power of the power of the lens, the IOL, and on postoperatively they give us the difference between before and after, and we have the if we have tilt or distortion of the IOL in the bag. To conclude, OCT sigma anterior is currently an essential tool in refractive surgery, whether corneal laser and phakic implants and premium toric and multifocal pseudophakic implants. The diagnostic management and the follow-up of keratoconus are based on anterior segment OCT. So in 22, no refractive surgery, no that of keratoconus without anterior segment OCT. Thank you.
Thank you so much, Dr. Mariam. It was a lovely talk. If any of the missing speakers have arrived, we still have got time if they would like to make their presentations. If not, then all the speakers who presented are here, and if there is any questions the audience wants to ask them, I think this brings to the conclusion of our session. Thank you so much to all the speakers. Yep, please.
He has focused the curvature of the cornea, you know, refractive power of the curvature of the cornea, interior surface and the posterior surface. But he has not mentioned about the density of, about the refractive index of the cornea, because after LASIK or SMILE, every procedure, the density of the cornea that is changed, the refractive power of the cornea that is changed. So it must have some effect on the cataract surgery as well.
I'm very happy you mentioned that point about the refractive index of the cornea change, which I myself, I don't know it. So I have to study and to see what's the refractive index of post-LASIK cornea. Is it the same like the refractive index? And it will be nice. It will be nice to... Definite. Yeah, it's a new point which I didn't think of. No, I look at, as I said, I look at the total corneal power as well as the peripheral of the cornea. I look at the center, I look at the periphery. But I don't have something related to the refractive index of the cornea post-LASIK. And I think if you have femtosecond LASIK, The refractive index should not be really that much change, because the femtosecond energy is so low and so rapid, so fast. Number of what? Yes?
Excuse
No.
me, can I chip in, please?
No.
Normally, the refractive index of the cornea is 1.336.
336.
And after femtosecond, the change is 0.02. So that's like so negligible that it does not have any effects.
Okay.
Changes up to 0.02. So that has got like a negligible effect on any measurements that we do as per IUL calculation.
Okay. Thank you.
Thank you, sir.
What was your next question? You said something about? No, not the refractive. You said something different. You said the power. You changed the power. No, the power is the same. Whatever the power of the myopia or hyperopia, it is the same power you use. What you use is the curvature. So it's the curvature which is changed. But it is the no change in power.
No, there is a change.
But
the
negligible.
change is so minimal that it does not have any value. Sir, you might have, but what I'm quoting is like the official data collected and presented and printed is 0.02. Negligible. So,
No, I cannot answer.
so
He answered beautifully. He said it is nothing. No, he knows.
please go ahead.
Thank you. In the subluxated lens,
Please. Yeah, please carry on.
in the subluxated lens, we have put the capsular ring after doing hydrodissection?
You can, certainly.
Because he put in rings.
That's a surgeon's choice, but if you want to ask Dr. Yahya, he can answer.
Yeah.
Dr. Yahya, can you answer the question, please?
You put in the iris hooks into the capsule. Instead of putting the capsular ring after doing hydrodissection. You could have saved a step and... Please.
I don't recommend using the iris hooks to hold the capsule.
But instead of putting those, they could have tore the capsule.
But not the capsular hooks. Capsular hooks will not tear the capsule.
But we could have avoided that step by putting the capsular ring after hydrodissection.
Yes, theoretically yes, but many times the capsule tension ring alone does not center enough the lens. So if it's minor subluxation, yes, you can put the capsule ring at the beginning if you want. But if it is a little bit like 3 hours or more, it's safer, or even more and more, like 6 hours, 7 hours, safer to put the capsular hooks. Then you can do the phacoemulsification and you implant the CTR later on, because the later you put it, the easier everything goes, the CTR.